Hi, everybody. Welcome. Thank you so much for being here tonight. I am so excited to um, really introduce our speaker for tonight. Michael's going to talk about diabetes and technology. He's an ambulatory care clinical pharmacist and certified diabetes care and education specialist with Stanford Primary Care across several clinics in the Bay Area. So he spreads out a lot of areas. He completed his doctorate in pharmacy from UCSF School of Pharmacy in 2001, after which he completed his residency at Stanford with a focus in ambulatory care, primary care. His main role is managing chronic diseases, which include diabetes, hypertension, hyperlipidemia, chronic kidney disease, among other disease states and responsibilities. And he's spoken for our group multiple times, and you all are in for such a treat. So without further ado, Michael, take it away.
Thank you, Leah. Good to see everyone. As Leah mentioned, I'm Michael and I'm a clinical pharmacist. And today we're talking about diabetes technology. So let me go ahead and share my screen and we'll get started. All right. So today we'll talk about two broad categories of diabetes technology. First, we'll start with technologies we use to monitor our glucose, our blood sugar. And then the second half, we'll talk about technologies we use for medication delivery. So why don't we go ahead and get started with technologies for glucose monitoring. So here on the screen, we have two different mainstays of how we check our blood sugar these days. On the left, you might see what's much more common, a glucometer. And on the right, you might see a setup that is called a continuous glucose monitor and different ways we use to connect with our sensors on the glucose monitor. So we'll start with glucometers. These are things that most people who have a diagnosis of diabetes or know someone with diabetes are familiar with. They measure whole blood glucose, and they're considered gold standard for point of care testing. So if you really wanted to know the blood sugar at this moment, the best thing to do would be to use a glucometer and check. It's the same thing we use in our hospitals and clinics. Now, with these kinds of machines, of course, you need several different components. You have your meter, you have a test strip that reads the blood sugar, you have a lancing device in the lancet to poke your finger. You might need additional things, alcohol swabs, logbook, other items to actually complete the whole process. So I think about using a glucometer. This may seem simple, but I always go over it. Inevitably, I always get questions during my appointments if things are done in the exact right sequence. This is what I would recommend. Before you start any procedure on testing blood sugar, applying a glucose sensor, giving yourself insulin or some other injectable medication, always make sure everything is as sanitary as possible. So wash your hands. At that point, you want to prepare your lancing device. This is a device that's going to poke our finger and get that drop of blood. The next part is the part I see the most hiccups with. It's about the fact that we have to insert the test strip all the way into the meter to put it in the mode to test it in. I've had many times where patients ask, well, how do I get it into that mode, or it's not turning on? The test strip has to be fully inserted, and only then is it ready to test your blood. It gives you about 60 seconds worth of time to poke your finger and get that drop of blood ready. So that's when we'll use the lancing device to poke our finger. Usually we recommend the side of the finger pad. You can go directly on the finger pad. It's a little more painful. Also, we use our fingers, so going onto the side is usually more recommended for comfort. I'd also say, the fingers we use less, they're more likely to get a good drop of blood with. If we're using our pointer finger or third finger a lot, they're more calloused, the skin is thicker. Using the fourth finger might be more ideal. At that point, you just bring your drop of blood over to the test strip, and then the result will appear on your meter. Ideally, these results should be recorded. When we make treatment decisions about blood sugar, most of the time this is done in the context of multiple readings, taking a trend into account and trying to adjust that trend to make sure that the blood sugar is, in fact, at goal. So what about tips? I think a lot of people are familiar with glucometers, so the steps I just talked about should be generally pretty familiar. Other things to think about. with a glucometer setup. There are lancing devices. Most of them have different settings for depth for the finger stick. So if you look at our lancing device down here, it's this white stick. You can see at the top, it has different numbers, and that's a rotating dial. The lower number means it's going to poke you at a shallower depth, so usually less painful. The higher the number, the deeper the poke, typically more pain associated with it. Usually when you get this out of the box, it's set to the medium depth. Here you can see it's set to 3, probably out of 5. If you feel like you have a lot of pain with your finger sticks, this might be one thing to look at. What is the minimum number I can set it to? What is the shallowest depth I can poke my finger, but still obtain an adequate drop of blood to measure my blood sugar? That's pretty much what you're looking for. Minimum amount of pain, but still obtain a nice drop of blood to make sure the test comes out and tells us our blood sugar. Other thing I've seen is making sure you understand where the reservoir is for your test strip. Most test strips look like this one down here, the even care one, where the tip of the end of the test strip is where you put a drop of blood and it sucks it right into the well, and then you get your result. But not all test strips are like that. In particular, Freestyle's company that produces a glucometer called the Freestyle Lite, and they use these test strips up here with the butterfly. And they have reservoirs on either end on the side. And I've seen a lot of times where I get questions about why the glucometer might not be working. And what's happening is you need to use the reservoir in the correct spot. So you would actually touch the side where this arrow is, the black half circle. That's where you would put that drop of blood to get your reading. In terms of using an alternative test site, if you can't use your fingertips for whatever reason, it depends on the glucometer. Every glucometer has a different tested alternative site. Sometimes it can be the palm. There could be other spots. It's hard to tell someone without knowing their glucometer. Typically, if you know what glucometer you use, it might be in the manual. You might need to call the manufacturer, but there may be an alternative testing site if fingertips are not working. And lastly, something else to consider is, if this process is a bit laborious, if this process doesn't work for you because there's too many components, you don't like the finger stick, you don't like using the lancet, etc. I've heard a lot of different things about using a glucometer that make patients uncomfortable. There are these all-in-one automated glucometers. One, the most common one I see of this example is the Pogo. So this meter is containing all of the components. It contains the test strip, it contains the poking lancet, and it contains the meter itself. So what you would do is you would put your finger on that blue circle you see down here on the Pogo meter, and from there it would poke your finger, use the drop of blood to check the sugar and give you your result up on the screen. So it's all in one. You don't have any other components. So that may be something that you like more instead of the different pieces of technology you need to operate a standard glucometer. Now, in terms of the regular glucometers, something to point out is if you're technology focused and you like having things automated, you don't want to have a logbook where you write everything down. There are a few glucometers that connect to phones and applications, and then they can log your results for you. They can create reports. You can send those reports to your doctor. One common one is the One Touch Vario Flex. It uses the One Touch Reveal mobile application, and this allows you to see your results in various forms. You can create reports, and then you can send off those reports to your doctor. What those reports would look like, something like this. So you can see it gives you, depending on the window of time, an average blood sugar, deviations, how often we're checking, the average before meals. So a lot of different statistics that really can help you and your provider understand, where we're seeing blood sugar fluctuations, what is particularly driving the A1C. The logbook view here shows, all of your results based on time. So on the top is the time, on the left is the date, and in the middle are the readings, and then it averages those out for you. And then also we have the AccuCheck guide. AccuCheck is another company that makes a pretty common glucometer that connects to a mobile application. And you get those similar pieces of information. It looks a little different, but it provides the same idea. It's logging your results, allowing you to see trends, and allowing you to see blood sugars at different times to understand, how is the picture overall looking for my blood sugars. Now, whenever we talk about glucometers, of course, we need to think about, when should we be measuring our blood sugar? It depends. There's not one kind of recommendation you can give everyone, but different time points tell you different information. So a fasting blood sugar is a really good blood sugar to check. Typically, this is done in the morning. You haven't eaten, for 8 to 12 hours since your last night's dinner. For this fasting check, you will get a good understanding of your baseline blood sugar. So there are two sources of blood sugar for the body typically, right? There's what we eat that contains carbs, that's going to turn into sugar. And then there's our liver. Our liver is responsible for releasing sugar to make sure that in the times that we're not eating, our body still has glucose to use for energy. So this fasting blood glucose level can tell you how well you're balancing that baseline level. It's not related to your diet, just seeing insulin resistance, insulin deficiency, depending on the type of diabetes you have, versus what your liver is producing, and is our medication balancing it out well. That fasting level typically is supposed to be between 80 and 130, but of course, all treatment goals should be personalized depending on your medical history. Now, checking after a meal is another good time, particularly 1 to 2 hours after, so you can see what fully digested meal means for your blood sugar. It can give you a good idea if the type of diet you have, the type of meal you ate is something that fits in with your dietary plans, with your blood sugar goals. Was it too little carbs, too much carbs, etc.? Typically, we want this to be less than 180 if you check your blood sugar about 1 to 2 hours after a meal, but again, the goals are always personalized. Now, other time points that I hear often being used with a glucometer is before meals and bedtime. In terms of before a meal, it can be helpful if you want to, check before and after to see the full effects of your meal. Typically, you don't want that difference to be more than about 50 points. Before you eat and after you eat, you don't want that jump to be more than 50 points. So if you do check before you eat, you give yourself that piece of information about the meal you had. The other time you might need to check before a meal is if you use that number to make a dosing decision. If you take mealtime insulin, you may need that before meal blood sugar check to understand what insulin dose to use. In terms of bedtime, this is just good to check if you have concerns about low blood sugar or you want to know what your blood sugar is before you go to bed to make sure that you feel like it's in a good range. That's what we'll cover for glucometers, pretty standard diabetes technology. Before we move on to continuous glucose monitors, we can take some questions if we have any about the glucometers.
You have some questions, but not about glucometers, so we'll wait to the end to ask those.
Okay, sounds good. All right. For continuous glucose monitors, also known as CGMs, so if you hear me saying CGM, that means continuous glucose monitor. So another way we check our blood sugar. It's probably one of the more popular ways to do it now. I advocate for a lot of my patients to use these systems. I find them very, very helpful. What you see on your screen here is an example of the two most common and current continuous glucometers or glucose meters. We have the Libre 3 on the left and the Dexcom G7 on the right. As you can see, they look very similar. You can see that they connect to a phone. They also have their own readers if you prefer that. And I believe the Dexcom also connects to your Apple Watch or smartwatch if you have that. So what are these continuous glucose monitors? What are CGMs? They're diabetes devices that measure your glucose level in the interstitial fluid. So what's important to note here is I'm not talking about blood glucose the way I was with a glucometer. I'm not talking about blood sugar. Although this is still checking a sugar level that is correlated, to blood sugar. It is something we still use to make treatment decisions. It is not actually measuring blood sugar. It's measuring the sugar in the fluid between our cells, interstitial fluid. The device consists of three components. You have a sensor, which is what's worn on the arm or the abdomen, depending on which one you have. You have a transmitter, and you have a receiver. The receiver can be that reader that it comes with. You can see that in the picture here. It could be your phone, depending on what your choice is. In terms of the transmitter, it might be combined with the sensor, so there's only actually two pieces. It might be its own thing. It depends on which CGM you have. And what it does is it measures your glucose level every 5 minutes if you have what we call a real-time CGM, or it measures it intermittently when you scan it. It's an intermittent scanning CGM. To quickly go over that blood glucose versus interstitial fluid glucose topic that I discussed, it's important to understand this because that's what the sensor is actually doing. So here you have in this picture a sensor, a transmitter. This is what's worn on the arm or the abdomen, the patch-looking device. So they have a little wire. That's what gets inserted into the skin. That little wire sits in the interstitial fluid, and it tries to measure the glucose around it. As you can see, the glucose is, in the bloodstream either because you had carbs or the liver is producing sugar. And it'll travel through the interstitial fluid to get to whatever tissues, organs it needs to get to provide glucose for those things. So it first starts in the blood and then it diffuses through into the interstitial fluid. Now, when you're in a period of stability with your blood glucose, when the change is not high, so what that's defined as is 1 to 2 points per minute, so you're not really changing much. The blood sugar and the interstitial fluid is nearly identical. There's no meaningful difference between the two, which is why we can use these devices. Now, in times of rapid change, so maybe immediately after eating, especially something very high carb or having something very sugary like a soda, or exercise, or in times of low blood sugar when there's a lot of fluctuations occurring, these devices are still very helpful, and we'll talk about why. But the changes might not be as rapidly reflected by their reading. Because your blood sugar is changing so fast, but the sensor reading is technically delayed because it's reading it from the fluid, you may not get the most up-to-date reading. In cases where you have low blood sugar with these sensors, or you feel like there's a lot of rapid change going on, it's not giving you the right result, the glucometer, as I said before, is the gold standard. That tells you exactly the blood sugar at that time. But again, for most times of the day, the sensor glucose is perfectly adequate to understand your blood sugar control and dosing decisions. So talking a little bit more in depth about the different components I mentioned, right? 3 components: sensor, transmitter, reader, receiver, depending on how you want to call it. The sensor is what we wear. So arm or abdomen, depends on which one you choose. We'll talk about which one uses what site. And is worn for a specified amount of time. So the Libre products are worn for 2 weeks or 14 days. The Dexcom products are worn for 10 days. The CGMs, they come with an applicator. So that's what you can see this person holding in their hand here. He uses this applicator kind of to stamp the sensor onto your arm, and then you move the applicator away, you toss it after you use it, and you're just left with the sensor on whatever site you use. And again, these sensors measure your interstitial fluid glucose either continuously or intermittently based on you scanning them, again, based on which product you choose. The transmitter, most often the times now, is connected to the sensor, and it uses the transmitter is there to send those results the sensor's picking up to your receiver so you can have that data. Most of the time, it's part of the sensors. You don't even see it as a different component. If you have like a Dexcom G6, for example, it's separate. So here in this picture, you can see a little gray tab. That's the actual transmitter. This white device, with adhesive, this purple and white device, that's the actual sensor. So in some CGMs, they are separated. In terms of the reader, they all come with a reader. It kind of looks like a glucometer, very similar, usually pretty small in size. Has a screen. It'll tell you the information that's coming out from the sensor. And also, you can connect it to your phone or even potentially a smartwatch. Now, I always advocate for patients to use their phone if possible for several reasons. One, most people carry their phone around with them. And so we're not forgetting the receiver. If you forget your receiver, you will stop getting that information from the sensor. It needs to be usually within 20 feet, if not closer, to be capturing this data the sensor is picking up. So usually we have less issues if we are already carrying our phone with that becoming a problem. The second reason I advocate for people to use their phone is by using the phone, you can automatically send your results to your doctor's office. So for my patients, I have them connect their account with our clinic, and when I see them, I can see all of the blood sugar information. I don't need you to read off any numbers. You don't need to come in and have me plug it into the computer. It's all automated. But again, if you use the receiver, it still works really well, but you don't have that data sharing aspect automatically. You would have to manually upload it to your computer, and then we would be able to see it at the clinic. Or at the clinic, we could upload it for you. So why would we use a glucometer versus CGM? A lot of it is to do with the amount of data we can get. So if you think about a traditional glucometer, so this would be like someone who's checking their blood sugar 4 times a day. They check at 8 a.m., it's about 100 points. They check it at 12, it's about 150. At 4 o'clock, it's maybe 140. And then at 8 o'clock, it's maybe, I don't know, 160, 170. Seemingly blood sugar looks really good, right? If we look at these 4 points, everything looks in control. But if we had replaced these 4 points with a CGM, we would get, this continuous piece of information. And actually what we're seeing is sometimes they're going low, sometimes they're going high. And if you didn't have the sensor on, you wouldn't know that because the glucometer just checks 1 point in time. Right? I have my blood sugar at this time. It doesn't tell me what's going to happen 10 minutes from now, 10 minutes before, unless I keep checking and keep poking my finger, which of course, we don't keep poking our finger all day long. Now with the sensor, it's connecting all of those data points because it's checking either every 5 minutes or every time you scan, and it's creating this picture for us to see exactly what's going on throughout the whole day. So then we can say, oh, actually, we don't want you to have these low sugars. We didn't know you had them. We need to adjust your medication. Or we didn't know you were having these spikes. Let's talk about our meals. Let's talk about our medication. What can we do to avoid these spikes that we didn't even know were there before? And so this is a wealth of information that we get from the CGM. In terms of what's called an ambulatory glucose profile report or AGP report, this is kind of the main report that is generated by a CGM. This is a lot of what your doctor is looking at, but it's still important for you to understand some of this information. This is particularly a Libre AGP, but all of the different CGMs provide you this data. So at the top here, you'll see the key metrics. So I'll tell you when the CGM was active. This is a 14-day CGM, so they wore it for 13 days, and it was active all the time. They never missed a scan. It was always turned on. So that's great. That means we can rely on the data. From there, you can see the average glucose for the period of time we're looking at is 173. It gives you this GMI, which is their predicted A1C. So they predict that with this kind of blood sugar control, your A1C would be 7.6%. Now, when you look at a GMI, it's important to understand that you're looking at 2 weeks here. And A1C is 3 months of data that heavily favors the last month. So it's not going to be exact, especially if you're not looking at a 3-month report. So just keep that in mind. If you ever get your GMI and it's much different than your A1C, they are different. A GMI is an estimation, A1C is a real value, and also the timelines might be different. But that's what their predictive, A1C is. That's what this glucose management indicator is. Then you have your variability, which tells you how variable your blood sugar is. We'll talk about a little bit about that in a second. And then on the right side of those key metrics, you can see when you're in range, typically 70 to 180 is what we consider a target range. So this person's 47% of the time in that range throughout the period of time we're looking at. 23% of the time, they're slightly above, so 180 to 250. 20% of the time, they're very high. They're also low some of the times. So that's what this little bar time and range piece is telling you. How often are you either in range, above range, below range? Then we have the actual profile. This graph is similar to the graph I showed you in that last slide, the blood sugar, but it's taking that whole 2 weeks worth or whatever you set your days to and putting it on a one graph. This dark line is the middle kind of number you get for that time of day. So this is usually where you're at. Now the dark shaded part, this blue shaded part, is 25 to 75% of your readings. So most of the time you're bouncing kind of in this area. The light shaded line is 5 to 95% of your readings. So it excludes some of the really big outliers, but it includes most of the information. And you can see this is a very thick graph. It's, you could be anywhere from having a low to a very high number. And that's why this person's variability is so high. So that's what that variability score is telling you. Lastly, down here, you have a daily profile. There's a better way to view this. You can log in and look at your daily graph every day, but if you generate the report, it'll also have a mini graph down below. In terms of these metrics, what are we looking for? What are our goals? Most of the time, you want to wear the CGM, all the time. You want to make sure it's as active as possible, because if your report is generated and it's only 50% active, we can't really say much because we only have half of the available data. So half of the picture we don't even know. We're only making a judgment on half of the information available. So the goal is to wear the CGM 70% of the time or more, or make sure it's active and being scanned 70% of the time at least, so that the decision we make based on the data is actually valid. The mean glucose, the average glucose, it depends on what your specified goal is. An A1C of 7% equals an average glucose of 154. So plus minus 30 points takes you up and down an A1C percentage point. So based on whatever your goal is, that's what the average blood sugar, the mean glucose goal you would set for yourself. Then you have your GMI, which you talked about, your A1C, and then your coefficient of variation, which you talked about, is your variability. Generally, if your variation is more than 36%, it's considered unstable. Here we have the time in range and time in target numbers. So as I said, target range is typically 70 to 180. You have level 1 and level 2 high blood sugar, so over 180, over 250. And you have level 1 and level 2 low blood sugar, under 70 is level 1, under 54 is considered level 2. For most people with type 1 or type 2 diabetes, being in range over 70% of the time is the goal. And then you can see the subsequent goals for the other, time points of blood sugar. So you don't really want to be really high more than 5% of the time. We never really want you really low. So you can see the goal is less than 1%. Now, there are other goals. So for example, for our patients who are maybe a little more frail, older, or high risk, we may loosen these, especially if you have a history of like low blood sugar, for example. We may want to loosen these because having tight control is actually going to cause more consequences. In that case, the goal may be to be in range just more than 50% of the time. And for pregnancy, we have different goals. You can see they're vastly stricter. So again, everything depends on your medical condition. Based on that, we generate goals, and we can look at the report to see if we're meeting those goals. In terms of the types of CGMs we have, as I mentioned, there's real-time versus intermittent scanning. Real-time CGM checks your blood sugar every 5 minutes. You don't have to scan it. You don't have to do anything besides make sure it's on and active. Your receiver's in range. You're looking at it, and every 5 minutes it's updating for the period of time that sensor is living. Intermittent scanning CGMs, most notably, this is the Libre 14-day or the Libre 2. These ones need to be scanned at least every 8 hours. If you let more than 8 hours go by, it starts dropping the data. So what happens when you scan it is it gives you your blood sugar and it fills in the last 8 hours of information. So if you only scan it once a day, you're losing, out of the 24-hour day, you're losing 16 hours of info because it can only hold 8 hours information on the sensor. So if you have a Libre 2 or a Libre 14-day, I usually recommend scanning at minimum 4 times a day. When you wake up, 2 times in the middle of the day, you could time it around your meals, and then right before you go to bed. That ensures that you don't allow more than 8 hours to elapse without scanning. So that's the main difference. Most of the new CGMs, so the Dexcom G6, the Dexcom G7, the Freestyle Libre 3, they're all real time, so they don't require you to scan. You just, look at your reader, look at your phone, whatever you're using to receive the data, and you can see your blood sugar full 24 hours. As I mentioned, these information can be shared. That doesn't matter which type, intermittent scanning or real time. The real-time CGMs also typically have better alerts. All of these CGMs can alert you if you're going low, if you're going high, if you're falling fast or rising fast. The real-time CGMs can also predict, especially the new Dexcom G7, it can predict if you're going to have a low within 20 minutes. So there is some benefits to some of these newer systems to keep you safe, especially those low alerts. They're very, very helpful. Here's a look at the difference of what I was talking about with what a real-time CGM versus intermittent scanning CGM looks like. The intermittent scanning CGM, you can see these holes in the graph. It's only giving you a result, only giving you an exact reading from when you scanned. The other time it's filling in the information, you won't get an exact reading, but you can still pretty much estimate where you've been. The issue is, for example, here we've checked at what looks like maybe 9:30, and the next day we didn't check till, after 11. That's more than 12 hours that went by. So you can see you've dropped that information because we didn't have that consistent scanning. Versus a real-time CGM, you can see the full graph is filled in. And I can't demonstrate it now, but when I hover my mouse over any part of this graph, it gives me the exact reading because it's checking every 5 minutes. So this is the advantage of the real-time CGM. No missed data, and every 5 minutes you get a real accurate number. In terms of the two main products, we have the Freestyle Libre products and the Dexcom products. This is the Libre products. Libre 2, Libre 3, these are the newest ones. They look very similar. The Libre 3 is a tad bit smaller. The main difference is the Libre 3 is real-time, the Libre 2 is intermittent scanning. They both have an integrated transmitter, meaning it's just one piece. The sensor is just one piece. You put it on, you take it off. There's no extra piece outside of your receiver. And you can use your phone. The reader, it says here to be determined, but actually it just came out. The Libre 3 reader just came out. So they both have readers, and they both can be connected to your phone. They're worn for 14 days at a time. They both have alarms for high and low sugar, and they're both worn on the back of the upper arm in that tricep area. There are some interfering substances with these devices. For the Libre particular, high doses of vitamin C. Typically, nobody needs to take this level of vitamin C, but if you have very high doses of vitamin C, if you take like an airborne product, for example, that might affect your readings. Also, high doses of aspirin can do that. The important to note, the Freestyle 14-day, which is like the original one, the first one that came out, the one before Libre 2, that one does not have alarms. So I recommend if you're still using that, you switch over to something that has that safety alert feature. And before you decide to pursue one of these, always make sure, if you plan to use your phone or you have a computer, that it's compatible with, the programs that it uses to collect that data. So, some older iPhones, I think if you have something less than an iPhone 7, they may not be compatible to scan, so you would have to use the reader. Some Android devices, depending on which one, may not be compatible. Here we have the differences between the Dexcoms, so the two latest ones, the G6 and the G7. They're both real-time CGMs, so no need to scan. The biggest difference, as you can see, one is quite a bit different shape. The G6, a little bit bigger, and it's also supposed to be worn on the abdomen. That's the FDA-approved site. Now, it can off-label be worn on the arm. It's done in Europe. It was never, the paperwork wasn't submitted for FDA approval here, but if you really needed to, you could technically talk to your doctor to see if the upper arm is available, but most of the time it should be worn on the abdomen. Also, the transmitter and the sensor are two separate pieces. The sensor lasts 10 days, but the transmitter lasts 90. So you attach them together when you put the sensor on, and then you reuse that same transmitter for 90 days while you change out the sensor. This is a little more complex, so like one more component, one more thing you might have to pay for, a little more hassle, so just keep that in mind. The G7 is much smaller, very similar to the Libre in size. It's all in one, sensor transmitters, put together. It's worn on the upper arm versus the abdomen. So much more similar to the ones we just talked about. They both have alarms and they both have hydroxyurea or, very high doses of Tylenol that might affect their readings. Now, we talked about how great these are. Why don't all of my patients have CGMs? The main reason is insurance coverage. Of course, if you don't prefer to have one, you may not need one. But if you prefer to have one, the main barrier may be insurance coverage. Now, in terms of if you have commercial insurance, meaning, private insurance through your employer, they make their own rules. It depends on which one you have, whether they will cover it or not. Some are very liberal with their coverage. Anybody with diabetes can get one. Some say you need to be on insulin, or you need to be on insulin multiple times a day to be covered. Sometimes it might be your prescription insurance that covers it. Sometimes it might actually be your medical insurance that covers it. That makes a difference because if your prescription insurance covers it, you can go to the pharmacy and have them bill it and get it. If your medical insurance is covering it, you need to go through a specific durable medical equipment supplier. So there are some caveats even with commercial insurance. Now with Medicare, it's important to understand that Medicare Part B is the one that covers diabetes supplies, not Part D as in drugs, the one that covers all your prescription drugs or most of your prescription drugs. Part B as in boy is the one that covers medical equipment, including glucometers and continuous glucose meters like a CGM. So that's the first thing to note. This year, the guidelines have changed for what Medicare uses to cover a CGM. You need to be taking insulin at least once daily. Before you had to take it at least 3 times daily. Now they've loosened it, saying if you're just taking insulin at least 1 time daily, you are covered. There are a few additional criteria. Mainly, you need to see your doctor every 6 months, whoever's managing your diabetes, and they will not reauthorize your approval unless they get notes from your doctor that you've been seeing every 6 months. You can see in this square the full kind of coverage criteria, but the insulin and seeing the doctor is the most common kind of inclusion exclusion I see. Now, if you have Medi-Cal, Medicaid, the coverage is very strict. I've rarely seen it covered, mostly for people with type 1 using an insulin pump or multiple injections a day. So it's very difficult to get coverage if you have, straight Medi-Cal. That covers the bulk of what we want to talk about with CGMs. The next part is going to be about medication delivery. Before I, run into that topic, do we have any questions about monitoring glucose, CGM,
Yes,
glucometers?
we do. We have some great questions. So one of them is if I use a CGM, do I still need to use a glucometer? If yes, when?
I love that question. Excellent question. If you use a CGM, you should still have a glucometer with you. It's very important that you have both. As I mentioned, in times of rapid change, the sensor may not give you the exact correct reading at that time, but the glucometer will. Most notably, you need this when you have low blood sugar. So if you have low blood sugar, it's not a bad idea to double check that with the glucometer. The sensor is a piece of technology, more so than the glucometer is. They can occasionally give false readings, and then they will need calibration. And in times of lows, because of that delay I talked about and the difference of how it actually senses the sugars, it's usually recommended to actually double check your blood sugar with the glucometer. Now, if you have a low and you're feeling the symptoms of a low, there's not really time for that. You need to correct your low blood sugar, and then from there, make sure that it goes up and test your sugar, a few minutes later. But if you get a low, for example, from your sensor, you're not feeling the symptoms, it's not a bad idea to double check to ensure it is actually a true low. One thing that can happen with the sensor also is if you sleep on it, especially if you have one on the abdomen or if you're a side sleeper and it's on your arm, if you compress the sensor against the skin, it often reads a compression low because it doesn't have any sugar to sense because the area that it's sensing is compressed. And so it can read a false low. So if you ever feel like the glucose is not matching up to what, the sensor is reading something that you don't think is quite correct, it's very high and that's not usual for you, you didn't eat anything that would cause that, or it's low and you're feeling like, I don't know why, I don't usually have lows, I don't feel like it's low, those are the times you want to use the glucometer. As I said, the glucometer is the gold standard. If you call the paramedics, they're going to come in and check it with the glucometer. That's what I would say. If anybody with a CGM, it's a good idea to have a glucometer on hand. Hopefully you don't have to use it, but these kinds of occasions you may need to use it.
Great answer. And then somebody else is kind of asking a question around post-meal blood sugar being above 200, and they're wondering kind of what that time duration is. I know you mentioned time in range and the 180, so I think they just want a little bit of clarification around that.
Yeah. So time and range is saying that, you want to be between your target blood sugar for at least 70% of the day or more. And you don't want to be above that too often. They say, between 180 and 250, you want to be in that range. If you're going to be in that range, less than 25% of the time that you're, of your day. In terms of it being over 200, how long it's going to stay there depends on what you ate. Lay, you probably even know this better than me. If you had a particularly large meal and it really spikes over 200, it's going to take some time to come down. But if you're looking at blood sugar 1 to 2 hours after you eat, and you're seeing that it's often spiking over 200, that would put two questions in my mind. One, what are the meals that are causing those results? And two, is my medication adjusted correctly to target those readings? Is it the fact that I'm starting at 150 and I'm spiking to 200? That actually might not be a meal issue, but the fact that we're already starting at a higher point doesn't allow us to stay in a healthy range if we have any sort of carbs. Or is it, I start the meal at 100 and then it ends up at 200, 250? Then why is that difference so large? What should we be looking at? Is it the medication that's targeting the mealtime glucose is not adjusted correctly? Is it the type of meal that I had? I don't know if that answers the question, but those are the things that come into my mind when I think about post-meal sugars.
Yeah, great. And then we have some other questions, but more around meters again. So I think I'll wait to the end and ask those.
This next part is going to go by much quicker. The bulk of it was glucometers and CGMs. So here we're going to talk about technologies for medication delivery. And what you see on your screen is a few of the different devices we use. Notably, I'm not going to be talking about pumps in this series. That's a very long topic, but if there are some questions, I can attempt to answer them after. So here you see a vial and syringe, kind of the original way we administered insulin to ourselves in our homes. Then we have an insulin pen on the right, which is mostly what we use now. There are other injectable medications in the diabetes space that use other types of devices, and those you see down here. So let's start with insulin vials versus pens. We don't really see a lot of vial syringe use nowadays. Mostly we use pens, and I think generally everyone agrees pens are much easier to use. In terms of an insulin pen, that's the diagram you see below. So insulin pen looks like kind of a thick pen that you write with. It's got a cap. When you take off the cap, you will see the medicine in this reservoir. Medicine, depending on the type of insulin you have, some of them may be cloudy, but most of the insulins these days need to be clear and colorless with no particles floating. Again, it depends. If you have a mixed insulin, that might not be true, but for most long and short-acting insulins, should be clear and colorless. There's a rubber seal. That's where you attach the pen needle. On the back end of the pen, you have a window which tells you the dose. You have a dialer to dial that dose, and you have an injection button. The pen needles come with two caps and a paper tab. So you would take off the paper tab and attach it to your pen needle, to your pen. And then there are two caps, this big one you see here and the small needle cap. And those are the components of your pen needle assembly. In terms of how to use a pen needle and other devices that, like for example, Ozempic or Victoza, they use a very similar style device. How do we use these? So a few steps, of course, wash your hands. I always start with that. Check your medication, make sure it's in date, it's the right dose, it's the right medication. It's clear and colorless if it's supposed to be. Like I said, there are a few insulins that may not be the case. From there, you want to attach your needle. So you take off that paper tab, you put it on and twist it until it locks. And then you have your two caps you need to take off, the big cap off the needle and the small inner cap. From there, you need to prime your pen. Most insulins need to be primed every time before you use them. Priming the pen means we basically waste a small amount of insulin and make sure that we can see the insulin coming out of the needle. That's the only way to confirm that when you actually give yourself the insulin, that the medication was coming out. it's not clogged or there's not some sort of other issue. So what you do is you hold the pen vertically, you dial it to 2 or 4 units, depending on the type of insulin you have. You press the dose button, and you should see either a stream or a few drops of medication come out the needle. And that tells you, yes, my pen is working. So when I give myself this dose, I'm confident that I've actually given myself the full dose. From there, you clean the injection site. Alcohol swab is most common. Dial your dose and inject it. You want to insert at a 90-degree angle. And you want to make sure the window, this dose window down here, is facing you. Because when you press the button, you need to watch it roll itself down to 0. So if I set it to 10 and I press the button, I will watch it roll down to 0. From there, I'll hold it for an additional 10 seconds. That makes sure that before I pull out the insulin, I know every last drop of insulin got in there. Keep in mind, most insulin is 100 units per milliliter, meaning a very small amount of insulin contains a lot of medicine. So you don't want to be missing out on drops. That's why we hold it down until it all the way, screws itself down to 0 and for an additional 10 seconds. From there, you remove the pen, take off the pen needle, toss it in your sharps container, and then, close up the pen for next use. In terms of doing that injection, for insulin specifically, you're injecting in the subcutaneous area. This is right under the skin into that fatty layer under the skin. You don't need to pinch when you do the 90-degree angle injection, but it can be helpful, especially if you're injecting in a place that doesn't have a lot of that fat underneath the skin layer. If you do pinch, just make sure you kind of get a broad area. You don't want to do a small pinch like this. And you're injecting it at a 90-degree angle. We're not going in sideways or kind of diagonally. It's going straight in. Remember, that needle is tiny. It's very thin. If I showed you right now on camera, you probably wouldn't really even see it. It's not going to go through to your muscle layer. So it goes in at a 90-degree angle. In terms of where you want to inject, the abdomen is most common, where we see a lot of good absorption for this kind of medication. But if that's not possible for whatever reason, there are alternative sites. Sometimes it depends on what medication and insulin you're talking about, but most insulins can be injected in the abdomen, thigh, or upper arms, sometimes the buttocks, but the thigh, upper arms, and abdomen are most common. When you inject, the other thing to remember is you got to rotate sites. You can't be injecting the same site, otherwise you'll develop some bumps and irritation from continuously injecting in the same area. So what's recommended is, you can go up and down, you can go sideways, you can go up and down. Just make sure you're not using the exact same site every single time you inject. So you can see some of those patterns down here. Other types of injectable medications, most commonly in the diabetes space, we think of our GLP-1s. These are, the new hot medications on the block, Ozempic, Trulicity, Mounjaro. A lot of them use the exact same type of device I just showed you. They're almost identical to an insulin pen. Two that are not and that are pretty common are Trulicity and Mounjaro. They're made by the same company, so they look identical. Here you have Trulicity. They are an all-in-one system. You don't have to attach a needle. It's one-time use. You can see it here. So it's got a cap on. First thing you do is take off the cap. This is the bottom end. You then unlock the pen. So this little area here twists and you go from lock to unlock. From there, with it pressed against the abdomen, which is where these medications are injected, you press the green button and it automatically will, lower itself, insert the needle, inject the medication, and then automatically will pull out. It takes about 10 seconds. If you're unsure, you'll hear 2 clicks. The first click is when you click the actual button, and the second click is when it pops itself back and it's done. It takes about 10 seconds. So this is just another type of device you may see. If you're someone who doesn't like looking at needles, you have a hard time with having to inject yourself, this might be more your speed, because all you have to do is place against the abdomen, push the button, and it does the whole thing for you. One newer device that I think is pretty interesting and has a good place in therapy is what's called a smart insulin pen. It's made by Medtronic. It's referred to as the InPen. It's a reusable insulin pen. Keep in mind, it only delivers fast-acting insulin, a mealtime insulin, so Humalog, Novolog, Fios, but those are all compatible with this pen. The device, why is it different than a regular pen? It's actually tracking your doses, and it can connect to a CGM and show you when you've taken the dose automatically. You don't have to record when you took it. You don't have to record how much. It automatically knows how much insulin you gave and when you gave it. And it can connect it to itself to your continuous glucose monitor and overlap that information, which can be very helpful when thinking about, mealtime. If my blood sugar is up, I can see, oh, did you administer the insulin? Did you not? Maybe it's up because we just didn't do it. Maybe it's up because it wasn't enough, and we can tell because we know how much was administered. The other thing that the app has, because it connects to an app to get all this information, the app can calculate your dose of insulin for you. So we can input in the settings what your regimen is, and it can tell you, right now you should be dosing this much insulin based on, the prescription and the discussion you've had with your doctor. What's also nice is, if you take insulin close together, say your breakfast is at 9 a.m. and your lunch is at 12. Well, short-acting insulin may last longer than 3 hours. So you could potentially give yourself that next dose of insulin and go low because some of that other old insulin from breakfast is still there. This pen would be able to subtract that insulin on board, is what we call it, subtract the amount of insulin you still have in your system to know how much to give if your doses happen to be close together, so you don't end up having too much insulin and then having a low. Those are some of the main advantages of the system. In terms of which CGM it's compatible with, right now only the Dexcom G6, so keep that in mind. This is what it looks like. So real quickly going back, this is what the results would look like. So when it's connected to a CGM, you have your CGM data here, just like we saw before. But now we have the insulin administration information. So it's administered here, and you can see that that's what that green dot means. And we talked about priming the pen. It automatically erases the priming, so it doesn't muddy up the info. So you can see it's overlapping this information of insulin that I've taken and how does that affect my sugar, and I can see all of that right away. What does this pen look like? It looks like a traditional insulin pen, everything very similar to what we talked about. The difference is it's reusable. What does that mean? This clear area is not an actual reservoir with medication in it when you get the pen. When you get the pen, it has an area to put a cartridge. And so what you do is you refill your insulin like you would refill an insulin pen, but instead of getting a pen, you get a cartridge that you place inside of the pen. And then that's again connected to the app, which I told you about, which will show your blood sugar. It'll show the CGM you've connected to if you're doing that. It'll show all of the administrations of insulin you've done for that day. You can generate a report, fax it, or email it to your doctor. So it's really integrates all of your technology. As I said, the pen are refilled with a cartridge. In terms of cost and coverage of the pen, if your pen is not covered, the manufacturer will allow you to get it for $35. If your pen is covered, then great, it's cheaper than that. But if your pen is more than $35, you can contact the manufacturer. They will fill out paperwork, and it will be $35. You usually only need to purchase it one time a year. If it breaks within the year, the manufacturer replaces it under warranty. If it's been more than a year, you should probably refill it and get a new one because it's only designed to last 1 year. All right, coming close on time, this is the last technology I'll talk about today. This is the Secure Simplicity Insulin Patch, another way to deliver rapid-acting insulin. Again, we're talking about rapid-acting insulin, not your long-acting, not your Lantus, not your Tresiba. This is a wearable insulin patch. You wear it for basically 72 hours, not more than that. It should last the whole time, so 3 days. It uses Humalog or Novolog, but really any rapid-acting insulin would work. And every time you click it, you can see this person here is clicking the dose buttons. Every time you click it, it delivers 2 units. The patch itself holds 100 to 200 units. Depending on how much you use is how much you would fill it with. Why is this helpful? Why would anybody want this? It helps minimize how many injections you use per day. So if you're someone that takes short and long-acting insulin, that means you're using about 4 injections per day, at least. Maybe 3 if you have 2 meals a day. That's a lot of things to do while you're trying to live your regular life, especially if you're out. I have a lot of people tell me it's not very comfortable to have to go to the bathroom and use my rapid-acting insulin and then come back to the table and that whole procedure. With this on, you could very easily give yourself the dose and then eat 10, 15 minutes later. And I think often it promotes the fact that it allows us to always have our insulin with us in cases where plans change. Diabetes is very hard to deal with every day because it's always there. We're always thinking about it, but we also want to live our regular life. And when plans change, these kinds of devices are easier to roll with those changes. And in terms of insurance coverage, as I mentioned, all these great technologies, insurance always is usually the main barrier. It can be tough to get coverage, especially if you have Medicare or Medi-Cal, but it really depends on what you have. The company does try to do their best to provide, some assistance, but depends on your insurance. I have some patients that get a month's worth of these insulin patches for $10 a month. For some people, it's $75 a month. It really depends. But if you're interested, and you and your doctor find it is appropriate, it's not a bad idea just to see what the coverage is and send it to the pharmacy. This is how you would fill it. So it comes with this filling kit. So you use a syringe, and you just have a vial of insulin. You pull out how much insulin you plan on inserting into the patch. Again, 100 to 200 units. So you fill it. You use this applicator, kind of like a CGM, to attach it to your abdomen, and then you're left with just the patch in place there that you use for 3 days. And that's it. Any questions on that or anything at all that we've covered today?
Yeah, you have a lot of really great questions. We are ending the end, so we'll just do rapid fire. If you want, you can stop sharing your slides, and then I will just ask lots of questions, and hopefully we'll get to as many as possible. So thinking about how do you get calibration fluid for blood sugar testers? Why is it so hard to find?
Yes, it is really hard to find. I will say you shouldn't really need it. To be honest, I haven't encountered this very often. What I would do is I would call the manufacturer. That would be the most straightforward way to get that answer is call the manufacturer. The other thing you might do is if you feel like your glucometer, or we're talking about the glucometer, not a CGM, if your glucometer is not, giving you the correct results, you may be able to get a new glucometer. If it's been more than a year, most insurances will cover it. If it's been less than a year, you may want to see if the company will fully replace it. Most new glucometers do not need to be calibrated. But if you really wanted the calibration solution, to be honest, I don't have a great answer for you outside of calling the manufacturer. That's probably what I would do.
Okay, and then the next one that came in was for somebody living with prediabetes, would you recommend them having a glucometer to make better food choices or to monitor their blood sugar?
Yeah, if you have prediabetes, I don't know that you medically, clinically really need one, but I think it could be helpful to help make those dietary changes if that's what you're looking to use to get yourself out of the prediabetes range. It doesn't hurt to know that information. Whether you absolutely need it, I don't know. I don't think so, but why not? If you're willing to see the results and use that to make decisions, I think it's a great idea.
Great. How long can I keep my insulin pen before getting a new one? Do I use it just until it's empty? And do I refrigerate it between?
That's a great one. I almost stopped myself to talk about this. So how long your insulin pen lasts depends on the specific type of insulin. I can give you the most common range. Insulin that's unused needs to be kept in the fridge. When your insulin pen is not used and in the fridge, it lasts for however long the box says so. Usually it's quite a while. Once you start using it, you don't have to put it back in the fridge. It's going to expire usually within 28 days, regardless whether you put it back in the fridge or not. Most insulins last 28 days after first use. Now, there are exceptions. For example, mixed insulins like Novolog 7030, that will only last 14 days. Tresiba, that typically lasts 56 days. So there are some exceptions to the rule, but common insulins like Lantus, Humalog, Novolog, Toujeo, those last 28 days after first use. You do not have to put it back in the fridge. Also, don't want to freeze it. Don't want to have it in a really hot place.